sir.
No, wait, man. Sir will say wait.
Just setting up the YouTube. So it is 8 o'clock. Good evening, friends. Very happy to have you all on this auspicious day, Ganesh Chaturthi. I wish and seek blessings from God Almighty and seek His blessings for ongoing academic program, which I have been doing for the last 99 classes. So we are happy to have eminent faculty today. Professor Sri Kumar Ramchandran will be shortly joining. We have Professor Srinivas Pai, head of the department from SDM Medical College, Dharwad. We have Professor Vivek Srivatsava and we have Professor Mumtaz both from Banaras Hindu University. I hope they will be joining shortly. And we have our resident faculty, Professor Rajiv Sahai sir, Srinivasan sir, Hitesh sir, and many other seniors who have joined us in YouTube. I wish all a very warm good evening. We have two important cases. One is kindly contributed by Professor Hemant Kumar sir, Pooja Jain from Himalayan Institute of Medical Sciences, Jolly Grant, Uttarakhand. And we have Dr. Vaishnavi Sai, who is from Institute of General Surgery, Madras Medical College, kindly contributed by Professor Goparan Devi ma'am under the directorship of Professor R. Kannan. By the time Dr. Pooja settles down, let us have Dr. Sai Vaishnavi to start her presentation. Dr. Sai Vaishnavi, please share your point. Please introduce yourself, your unit chief, and then start your PowerPoint.
Yes.
Faculty who have joined new, I would like to briefly tell, the candidate will be allowed to run through the history part of it. We stop there and then you can ask questions, taking back the slides from 1, 2, 3 like that. And then let the candidate be allowed uninterruptedly to present till the diagnosis. Then we can stop there and discuss initially on the clinical finding. Later, we move on to the investigations and management also. They have got some investigation slides also, so that can be perused for discussion. So the invited faculty takes the priority first, and then the resident faculty definitely will be able to add a few of their comments and points. Good luck, Dr. Vaishnavi. Please start.
Thank you, sir. Good evening, sir. Good evening, ma'am. I'm Dr. Sai Vaishnavi from Institute of General Surgery, MMC. I'm presenting a case of peripheral arterial disease under guidance of my unit chief, Dr. Goparan Devi ma'am, and director, Dr. Kannan sir, and our assistant professors, Dr. Vimla ma'am and Dr. Joyce Prabhakar sir.
You can keep your video on, ma'am.
Yes, sir.
Yeah. You're good to go, ma'am. We are able to see your slides.
Yes, sir. I'm just switching on the slideshow, sir.
Okay.
My patient, Mr. X, a 38-year-old male who is working as a cook in a hotel coming from Salem, presented with chief complaints of history of pain in the left foot for the past 6 months, history of ulcer over the left foot for 4 months, history of pain over the right foot for the past 4 months, and history of pain over the right hand for the past 1 month. A history of presenting illness. My patient was apparently normal 6 months back, after which he developed pain in the left foot for 6 months duration, more over the calf and the foot region. Is intermittent claudication, cramping type of pain. It was aggravated on walking and elevation of limb and is relieved temporarily on hanging legs down. Initially, patient had pain during walking distance of 500 meters, which was relieved temporarily. Which was relieved temporarily on taking rest, and he continued walking. Now he complains of pain walking for a distance of 100 meters. The claudication distance here is 100 meters, sir. Now he developed severe pain that occurs even during rest, which awakens the patient from sleep, which he manages by holding his foot with hands. History of ulcer over the left foot for the past 4 months. Initially started as a blackish discoloration of the first and the third toes, followed by blister formation that broke down to form an ulcer. History of first discharge from the ulcer for the past 20 days. Treated conservatively at a government hospital.
Vaishnavi, for a moment. Vaishnavi,
Sir?
just hold for a moment. We have
Yes.
Professor Ajay Khanna sir and Professor Mumtaz Ansari also joining up. Welcome, sir, both of you. Please continue.
Yes, sir.
Thank you very
History
much.
of pain. History of pain over the right lower limb for the past 4 months duration in the region of the calf and foot. It's a cramping type of pain, aggravated on walking, and there is no history of wrist pain. History of paresthesia over bilateral lower limb for the past 4 months. More over the foot. This continuous type. Nature of pain is pin and needle sensation. History of pain over the right upper limb. More over the right hand for 1 month duration. Aggravated on elevating the limb above the head. There's no history of trauma. There's no history of postprandial abdominal pain. No history of syncope. No history of sudden blackouts. No history of blurring of vision. No history of chest pain or palpitations. No history of impotence. No history of neck pain or restriction of neck movements. There's no history of discoloration of fingers on exposure to cold. Past history. Patient is not a known case of diabetes mellitus or systemic hypertension, ischemic heart disease, seizures, or COPD. No history of coronary artery disease, CVA, or transient ischemic attacks in the past. Patient gives history suggestive of lumbar sympathectomy, which was done 4 months ago at a private hospital. History of treatment done for the ulcer over the left foot at a nearby hospital. Personal history, he consumes normal mixed diet. He is a smoker for the past 20 years. He smokes around 25 cigarettes per day. The smoking index is 500. History of alcohol consumption for the past 20 years. He consumes around 180 ml per day. Treatment history, patient is not on treatment for any chronic illness. Family history, there is no history of similar complaints in the family members. Summary, a 38-year-old male with history of smoking with no known comorbidities, with complaints of wrist pain in the left foot for 6 months, intermittent claudication pain in the right foot for 6 months, blackish discoloration of left foot with ulcer over the left foot for 4 months, and associated with pain in the right upper limb for the past 1 month.
Hello.
Sir?
You can go to your first slide, Ma. So,
yes, sir.
Faculty speak. Please, sir. Vivek, sir.
Yeah. Sai.
Sir? Good evening,
yes.
sir.
Good evening. So you presented your history. You said that the pain the patient was having was a claudication pain. You specifically
Yes,
mentioned it was a claudication pain.
Yes, sir.
So what is the exact nature of a claudication?
Claudication is a cramping type of pain which the patient gets when he does any physical activity, which makes the patient stop his physical activity, make him take rest, and every time he does the activity, the pain is reproducible. Sir.
So one point still is missing, that the pain gets relieved when the patient takes rest. So how much is this duration of rest normally? Normally the pain should subside after how much period of rest?
It usually subsides immediately, sir. It doesn't take a longer time, sir.
Yeah,
he gets immediate.
It doesn't take a longer time, maybe say 5 to 10 minutes.
Okay, sir.
What is a pseudoclaudication? I mean, pain which appears like a claudication, that means it starts with some physical activity, continues when the patient moves, but exactly it is not of a vascular origin. Claudication pain is associated with some arterial disorder.
Yes,
so it's not due to some arterial disorder, maybe some orthopedic or neurological problem, like a problem in the spine. So
yes,
how does this differs from a actual claudication pain?
In claudication pain due to arterial cause, the patient will not have pain on the initial step, sir. He gets
Okay.
pain after he does activity for a few minutes.
Okay.
Whereas in neurogenic cause of claudication, patient will have pain at the initiation of any activity, sir, and it is not relieved by rest. It is usually relieved on attaining certain postures like stooping forwards or sitting postures, sir.
Okay. Can a claudication pain due to a arterial cause occur while sitting or at rest?
Yes, sir.
Usually it doesn't happen. So that is
Okay, sir.
one difference by which you differentiate a true claudication from a pseudo claudication.
Okay, sir.
Do you know, based on the type of pain, a claudication pain, can you classify the patient's claudication pain? Is there some classification based on claudication?
Yes, sir. This Boyd's classification, sir.
What is that?
Class 1 is the patient will have pain during walking. He continues to have the pain, but it gets relieved over a period of time and he continues walking, sir. Second one is he'll have the claudication pain. The patient is forced to take rest and then the pain subsides and then he continues walking, sir. The third is the patient will have pain on walking, which the exercise or the activity is restricted due to pain and he will not continue further, sir. And fourth is he is having pain on rest, sir.
I think that's an error, Vaishnavi. Because claudication pain should not occur at rest at all.
Okay, sir.
That's a common error. Boyd's classification has only
Yes.
3 grades.
Three grades.
Not 4.
Okay,
Exactly.
sir.
And your second grade is patient has pain and continues to walk. Limping. That's how they get the word claudication, means to limp.
Limp. Okay, sir.
From some Roman emperor Claudius, I think.
Okay, sir.
Okay, who was to have polio, so is to limp. So that's how we get
Okay,
the
sir.
word. Okay.
Okay, sir.
One more thing is claudication pain should not occur at rest at all. Okay.
Okay, sir.
So the definition what sir asked you, Professor Vivek asked you, is pain brought about by walking an accustomed distance with 2 caveats, 2 conditions has to be fulfilled. Should not occur at rest and should
Okay, sir.
occur after taking a few steps.
Okay, sir.
And that posture he was talking about in pseudoclaudication or neurogenic claudication occurs in lumbar canal stenosis, intervertebral disc prolapse. It's called as a simian posture.
Okay, sir.
He takes a posture like a chimpanzee or a gorilla, the forward, because that makes the spine relieve the
Relax.
pressure on the nerve root.
Okay, sir.
Okay. So
Okay,
Boyd's classification, only 3 are there. Okay. Rest pain is an
Okay.
independent symptom of claudication.
Okay, sir.
See, in your history, you have not mentioned the claudication site. It's important, isn't it?
Yes.
Where
Yes, sir.
exactly the claudication site is, what has it got to do with the block? Can you harbor a guess and tell where the block could be based on this history which you are given? Or the
My
CT scan and other findings, based on the history.
my patient had pain over the calf and the foot, sir.
Yes.
So it will. I expected it to be one level above, sir, at the region of femoropopliteal or femoral region.
But in the history, you have given the left foot, the other foot, and also the right upper limb. So that's
Yes,
what
sir.
sir is asking. See, you said 1 foot, but you are talking about 1 foot. But in the history, you are told about the right foot
The other
and
foot.
the right upper limb.
Yes, sir.
So where do you think the level of?
Probably iliofemoral, sir. But he doesn't give history of any pain in the gluteal region, sir. That is why.
Based on your history, do you think it's just 1 block or multiple blocks, or
No.
is it generalized disease?
Multiple, sir.
You go to the history slide now. First, just a minute. Okay, left foot it started, then you had an ulcer of the left foot. So there is
Yes, sir.
progressive in the left foot.
Left foot.
Then you
Yes,
said
sir.
history of pain of the right foot,
Yes, sir.
4 months. Now he
Yes,
has got
sir.
history of pain in the right hand,
For
1
the
month.
past 1 month. Yes,
So
sir.
that is what sir wants from your history. Is it single block or multiple block? Sir, please, sir, just hit.
See, what I'm
Multiple.
hinting at is multiple blocks. You're absolutely right. And what could be the disease? Because it's involving both limbs, upper limb also. Patient is not a diabetic. Yeah.
It could be Berger's disease, sir.
No, you see the occupation of the patient. You said you have put the answer in your history itself. Working as a cook in a hotel,
Cook.
so hate
Yes,
of
sir.
pain in the right hand. Please, ma. Sir, please, sir.
Berger's disease is right. TAO.
Yes, sir.
Burgeritis
Yes, sir.
Okay. So do you think this is critical limb ischemia or not? Based on your history alone.
He has pain during rest, sir. So
Yeah.
it is, and he has an ulcer.
Yeah. Correct.
And the claudication distance, he says, is 100 meters, sir.
What is critical limb ischemia? What is critical limb ischemia? CLI.
If the ankle brachial pressure index less than 0.3,
I'm not talking
sir.
about any test. Is there, based just on your history, can you tell this is critical limb ischemia?
Any ulceration or gangrene, sir?
No, rest.
Claudication
Number
distance.
1, grade 3 claudication. What's the claudication grade in your patient? What is the, based on the Boyd's classification, what is the
Grade 3,
grade
sir.
of the grade 3? Rest
Grade
pain
3,
is
sir.
also there.
Yes, sir. Rest pain is
And
also
the
there.
wound is not healing, isn't it?
For 4 months, sir.
So you don't even need to investigate to do any other test, even clinical examination based on history itself.
Yes,
You
sir.
can straight away say it is TAO because there's no diabetes, upper limb involvement, and
Yes, sir.
critical limb. Yeah. 99% of your work is done with this excellent history you have taken, isn't it?
Yes, sir.
Yes. So that's
May I
why
come?
is very important in the a vascular disease.
Yes, sir.
Okay.
May I come in, please? Sai,
Please, sir.
this is Dr.
Please, sir.
Sahai.
Sir.
Please, sir.
Good evening, sir.
Good evening. Does the patient have Raynaud's? Have you asked for the history for Raynaud's?
I asked history for Raynaud's, sir. He does not give any history of discoloration of the fingertips on exposure to cold.
I didn't see it on your
and,
history. Okay, what is the importance of Raynaud's in this patient? Raynaud's is because Berger's is a neurovascular bundle disease.
Yes, sir. Yes,
So
sir.
Raynaud's is commonly associated with
TA.
TAO rather than atherosclerosis.
Okay, sir.
Okay.
Okay, sir.
What about, you said this, why is the pain more at night? Any reason why you think the pain, if the pain is more at night?
Sir, the patient usually assumes a supine position, so the effect of gravity is negated, sir.
Okay, very good. What else? It is cooler at
in
night?
supine, sir?
It is cooler at night? The temperature is less at night than the daytime? And there's less distraction. These
Okay,
are the
sir.
factors.
Patient concentrates more on the pain. Okay, sir.
And he said, you said he sits with his, holding his foot with his palms. Why does he do
Yes,
that?
sir. Sir, his hands are relatively warmer compared to his foot, sir. So he's comfortable wrapping his foot in his hands.
Right. So that warm hand dilates his
Yes, sir.
vessels. Okay, that's right.
Yes.
And he complains of needles and pins
Yes, sir.
sensation. Why
Yes,
is that?
sir.
Why is that?
There is associated peripheral neuropathy, sir, because history-wise, I presume him to be a case of TAO, sir, and TAO affects both the nerves and the vessels.
Okay, but in otherwise also there can be needles and pins because there's shunting of blood away from the skin.
Okay, sir.
Okay. Now, is upper limb ischemia common? It's less common than lower limb. Why? Why do you think it's less common than lower limb?
So the range of movements in the upper limb is relatively less compared to
No. I think upper limb is always as moving as much as lower limb. In fact, it moves more than the lower limb. It is nearer the heart, first of all.
Okay, sir.
Okay. There's less bulk, and they're good collaterals.
Okay, sir.
Right. So, which artery in the upper limb is most commonly affected if there is an affection? Is this brachial artery? Okay. I say this patient is not a case of Berger's disease.
Okay, sir.
Can you think of any other condition which this patient could be having other than Berger's, which can result in all this kind of features?
Sir, it could be atherosclerosis starting at a younger age, accelerated
Yes, very good. Accelerated atherosclerosis. What is that?
atherosclerosis.
What is that?
Um,
Berger's is very rare, actually. It's very rare. But what is accelerated atherosclerosis?
atherosclerosis starting at a younger age, sir.
What age? Around 18
there
years
can
of age.
be
18 years of age, okay. And it is usually associated with?
Sir, familial hypercholesterolemia, sir.
No. It's usually associated with autoimmune inflammatory disease.
Okay, sir.
Okay.
Okay, sir.
Please, sir, carry on. Thank you so much.
You said that the patient is 38 years old patient. Is that correct? See your first slide.
Sir.
Go to your first slide.
Yeah.
First slide. 38 years old male. Is that correct? No, it is not correct. No? 30 years cannot be old.
Okay, sir.
It's a 38 year gentleman.
Okay, sir.
Okay. Never say old at 38 years.
Okay, sir.
Even at 60, you cannot say it is old.
Okay, sir.
Okay. WHO has defined that even after 65, you can say it is old. But otherwise, they are just, you are not to say older. Like
okay,
that.
Sir.
Now, can you tell what is the Shenoy's criteria for the Berger's disease?
So the age should be less than 50 years, sir. There should be a history of smoking.
Yes.
There should not be any other contributing comorbidities like diabetes or hypertension, sir. Usually it is an infrapopliteal involvement is present, sir. And either upper limb involvement or superficial thrombophlebitis is associated, sir.
So how many criteria are fitting in your patient? Out of these
Sir,
5 criteria?
my patient's age is less than 50, sir. History-wise, he has pain in the calf and the foot, so you can take it to be an infrapopliteal disease, sir. He has pain in the right hand. There is an upper limb involvement. Then he has history of smoking, sir. He has no other comorbidities. Sir, 4.
So almost all the criteria.
Yes, sir.
Your patient is fulfilling all the criteria of the
Yes, sir.
Berger's disease. Now, can a patient of the peripheral vascular disease has a gluteal claudication? Now, we always say there's a claudication in the calf is there or in the foot is there.
Okay, sir.
But can you have the gluteal claudication also in the gluteal area?
Yes, sir. It is more due to atherosclerosis than thromboangiitis obliterans, sir. When the occlusion is at a higher level, like iotoiliac, there can be pain in the gluteal region, sir, and associated impotence can be there, sir.
Yeah, that's
What is that syndrome called?
A lyric syndrome, sir.
What is the triad of Leriche syndrome?
Sir, claudication in the gluteal region, impotence, and absent pulse, femoral pulse.
Okay.
Go on the examination now.
Yes.
One small comment. One small comment before examination, Dr. Pai here.
Yes, sir.
Good
The
evening, sir.
comment is impotence is an early sign of vascular disease. So be careful with this.
Okay, sir.
Impotence on its own is a early symptom of vascular disease. Okay. There need not be a block, actual block. Okay.
Okay.
Some of the significant amount of patients present with impotence as a symptom, they'll have peripheral atherosclerosis, but they won't have a aortic block. So
Okay.
in practice, be careful of this. Okay.
Okay.
In practice. Okay. Thank you.
Even the diabetes can be important. If the patient has the diabetes, he can be important.
Just a small point. You said that in the past history there is no history of diabetes.
Yes,
So
sir.
diabetes you should not say in the past history. Actually, either the patient is not a known diabetic or is a
Okay.
known diabetic, well controlled either on lifestyle modification or on drug or on both. So
Okay.
that should not be put in the past history.
Okay, sir.
Ansari sir, you want to ask?
Then yes, how do you differentiate between the pain of arterial or venous origin clinically, bedside? Am I clear?
Arterial pain, yes, sir. Venous pain due to venous disorders have a diurnal variation, sir. Pain is usually relieved towards the evening, sir.
Like if you elevate the limb, would venous
The arterial pain becomes worse, sir. The pain due to venous system the patient will
why
feel
does it
better on
become worse?
the effect of gravity is eliminated, sir, on elevation of the limb.
And why a venous origin pain becomes worse on
There is increased
hanging?
venous return on elevation of the limb, sir. The hydrostatic pressure also decreases, sir, on elevation of the limb.
Okay, okay. Thank you.
Sir, can we go
Please
on
go
to
ahead.
the clinical examination?
Yes, sir. General examination. My patient is examined after obtaining consent in a well-lit room after adequate exposure. Attitude of the patient: sitting position with legs hanging by the side of the bed. Is conscious, well-oriented, afebrile, moderately built and nourished. Hydration status is fair. There is no pallor, icterus, cyanosis, clubbing, and no generalized lymphadenopathy. There is nicotine staining of gums and fingers. There is no arcus senilis. Blood pressure is 130/80 millimeter of mercury measured in the left upper limb in sitting posture. Pulse rate is 92 per minute measured in the left radial artery. Normal in volume and character. There is no vessel wall thickening. Respiratory rate is 16 per minute. Saturation is 99% in room air. Height is 174 centimeters. Weight is 78 kilograms. BMI is 25.7. Local examination, inspection of the left lower limb. Skin: there is blackish discoloration noted over the dorsum of the foot with ulcer involving the base of the first, second, and third toes extending to the plantar aspect of the foot at the base of the first, second, and third toes. Gangrene of the third toe, which has a dry and shriveled appearance. The skin: there is loss of luster. There is loss of hair over the dorsum of the foot and toes. There is edema from the dorsum of the foot extending to lower 1/3 of the leg. There's no obvious muscle wasting noted in the calf or the thigh. No brittle nails. This is the ulcer, sir. Ulcer of size 4 cross 3 centimeters over the dorsum of the left foot, involving the base of the first, second, and third toes with necrotic patch. Ulcer extends to the sole, involving the ball of the great toe, plantar aspect of the base of the second and third toes, irregularly shaped. The edges are sloping. The floor of the ulcer shows necrotic debris and slough. There is no active foul-smelling discharge. Surrounding skin, there is blackish discoloration along with edema. There is line of demarcation is present. Palpation of the left lower limb. Temperature is lower compared to the right from the foot to the mid-calf. Dry gangrene of the base of the first toe and third toe. Inspectory findings of the ulcer size and extent are confirmed. Base of the ulcer, the base of the ulcer has the heads of the metatarsal 1, 2, and 3. Sensation is decreased over the dorsum of the foot and the sole. Movements of the toes are restricted. The ankle joint movements are normal. There is pitting edema in the surrounding skin. There is no tenderness along the veins. Capillary refill time and venous refilling time is prolonged. There is no crepitus. Right lower limb inspection. There's blackish discoloration from the dorsum of the foot to lower 1/3 of the right leg. There's loss of luster of the skin, loss of hair over the dorsum of the foot and toes. No obvious muscle wasting noted in the calf or the thigh muscles. No brittle nails. No ulcers or gangrene noted over the right lower limb. Palpation. Temperature is warm compared to the left lower limb in the foot, calf, and the thigh. No tenderness along the veins noted. Sensations reduced over the dorsum of the foot. Capillary refill time and venous refilling time both are prolonged. Right upper limb on inspection, there's no obvious discoloration of the right upper limb, loss of hair over the dorsum of hand and fingers, no ulceration or gangrene, no brittle nails or transverse ridges over the nails. Palpation, temperature of the right hand is comparatively cold to the left hand. Movements of the fingers, there is no restriction. Allen's test, there is failure on occlusion of right radial and ulnar arteries. Adson's test is negative. Examination of inguinal region, there is no inguinal lymphadenopathy. Right and left calf circumference is 35 on the right, mid calf 33 on the left, mid thigh is 44 and left is 45. Mid forearm circumference is 19 centimeter and left is 19 centimeter. Systemic examination, CVS S1 and S2 heard, no murmurs. Respiratory system, normal vesicular breath sounds heard and no added sounds. Per abdomen is soft, bowel sounds are heard and no organomegaly. Palpation of peripheral pulses. The common carotid, the brachial artery, brachial artery is normal on both the sides. Radial artery and ulnar artery and common femoral artery are feeble on the right side, whereas on the left upper limb, radial artery and ulnar artery is normal. On the right side, below the femoral artery, the popliteal artery, posterior tibial, anterior tibial, dorsalis pedis artery, there is pulses could not be palpated. On the left side, below the popliteal artery, the posterior tibial, anterior tibial, and dorsalis pedis could not be palpated. Case summary. 38-year-old male with history of smoking with no comorbidities, with complaints of pain in the left foot for 6 months, blackish discoloration of left foot and ulcer over the left foot for 4 months. On examination, dry gangrene of the left third toe with signs of ischemia, with absent pulses distal to femoral artery pulsations in right lower limb, and absent pulses distal to popliteal artery in the left lower limb, with right upper limb feeble radial artery and ulnar artery pulsations. My provisional diagnosis would be peripheral arterial occlusive disease affecting bilateral lower limb and the right upper limb with critical limb ischemia of left foot, probably due to thromboangiitis obliterans, with probable femoropopliteal occlusion on the left lower limb and infrapopliteal on the right lower limb and infrabrachial on the right upper limb.
Okay, hello, Sai.
Sir? Yes, sir.
Just can you go to your first
Yes,
slide
sir. Yes, sir.
of examination?
Yes, sir.
And okay, I mean where the pulse was there.
Sir.
Yes. So are you satisfied with the examination of the pulse, what you have described, or would you like to add something to it? Because I
Uh,
think pulse is the most important thing in this patient.
Yes, sir.
Yes.
Sir, radial and radiofemoral delay, sir.
Is it important in this case?
Mm.
Where do you get it, that radiofemoral delay, if I'm permitted to ask?
Yes, yes, sure.
Sir, in coarctation of
Yeah.
aorta,
Your
sir.
patient does not survive till 30. So 35 is the average age of a death of a coarctation of the aorta if it's diagnosed in childhood. Okay.
Okay, sir.
So the physicians overemphasize on this. It's in real life, you don't get it in adult patients. Okay. Right.
Yes, sir.
Something more would you like? Something more would you like to describe in the pulse? Not exactly that delay, but something else. Would you like to describe the amplitude of the pulse?
Normal amplitude, sir.
So you grade the pulse according to the amplitude. What is that grading?
Uh,
So it's like 0, 1, 2, 3. 0 is what? 0 is
Not
absent
able to.
pulse.
Absent
Yes.
pulse. 1
Yes.
is feeble, sir.
Yes.
2 is
Diminished or-
normal. 3 is
Yes.
bounding.
Okay. So in a peripheral arterial disease,
Yes, sir.
you should at least describe the amplitude. That is very
Okay.
important. Whether
Okay,
the
sir.
amplitude is normal, it's decreased,
Okay, sir.
what is there.
Okay.
Acha, you said that the right lower limb was blackish from
Yes,
the
sir.
foot up till the lower 1/3,
Yes, sir.
but the temperature was warm.
Sir, compared to the left lower limb,
Of
sir, I
course,
felt
the temperature you can only tell when you compare to the contralateral side.
yes,
Otherwise,
sir.
you cannot comment.
Yes, sir.
So, can you explain this?
Probably he has collaterals forming, sir. So
So the disease process has happened. It's common for all the 4 limbs.
yes,
So
sir.
why it should happen only in the one limb? Any other reason?
Sir, because of the pain in the left foot, he has restricted his activity, sir.
So, but whenever you examine the patient, usually the patient is at rest for some period
Yes,
of
sir.
time. So that activity, whatever change can happen with the activity is not there. You said that there was a pus discharge also. From which limb?
Left, sir. Left lower limb, sir.
From the left. Can infection lead to an increased temperature, even in the presence of a gangrene or ischemic
Yes,
limb?
sir. Due to
You-
associated inflammation, there can be an increased local increase of temperature over the surrounding skin, sir.
So while you were doing the patient examination of the lower limb, did you look
Yes, sir.
for Berger's angle? Because you said that your diagnosis is Berger's disease.
Yes, sir. I looked for Berger's angle, sir.
What is that?
It is the angle the patient is made to lie supine, and one leg after the other is examined, sir. Without flexing the knee, the patient is asked to lift the lower limb, sir. It is done. We have to see at what angle the patient gets pain. This patient got pain at 30 degrees, sir.
So normally, whatever examination you do, you should not incite any pain to the patient.
Yes,
So
sir.
pain is not what you see; it's the
Pallor.
pallor.
Yes, sir.
So what was that angle?
Sir, 30 30 degrees.
30 degree. And what is the angle for the critical limb ischemia?
So 20 degrees, sir.
So if it is less than 30, it's a critically ischemic limb.
Ischemic. Yes, sir.
Can you describe the finding of the Allen's test you described? You just commented Allen's test. What was the
Sir,
finding?
Sir, on occlusion of the radial artery, the hand remained pale only, sir.
On the occlusion of the
Radial artery, the hand remained pale only, and even on occlusion of ulnar artery, there was no return of color to the hand, sir, after making a fist.
how do you do Allen's test?
Patient is asked to make a fist, sir, and we compress the radial artery and we make him open the fist.
So what will be the finding?
Sir, there'll be normal return of color, sir.
No, first
the-
whether the palm will become pale or not.
It will become pale, sir, but it will
Only by occlusion of the radial artery. Or you have to press both the radial and the ulnar artery.
press both radial and ulnar, release the radial artery first, and then look for again ulnar artery.
So you simultaneously press both the radial and ulnar artery and ask the patient to open and close the hand.
Okay,
And
sir.
finally, when you after say few minutes, you ask the patient to open the palm, it will become pale.
Pale.
So you release one side radial artery and see whether the hand is getting returning to back to normal color or not. So in this way, you can say whether the radial artery is blocked or the ulnar artery is blocked.
Okay, sir.
What type of gangrene was there in this patient?
Sir, it was a dry gangrene, sir.
What is the characteristic of it? Yes.
Sir, dry gangrene, the toes are usually have a mummified or a shriveled appearance, sir. There is a line of demarcation present, sir. Then there is usually no associated discharge.
Edema.
There is no edema, sir.
But you commented that there is a edema.
In my patient, he had edema, sir, and he gives history of minimal discharge also, sir. On examination, there was no active discharge, sir. Probably the gangrene would have become secondarily infected.
Okay.
Vaishnavi,
Yes, sir.
Dr. Sai, you've taken the blood pressure on the left hand, left arm.
Yes, sir.
Why didn't you take the in a vascular case? I would have expected you to take the blood pressure in both the arms. Is it important?
Yes, sir.
Why is it important to take the blood pressure in both the arms?
Yes, sir.
Why is it important? Because there could be, there could be just that the blood pressure, the flow is slow in one arm, and we would know whether the obstruction is already proximal to that or not.
Okay, sir.
Have you examined the spine of the patient?
No, sir.
You have not, right?
No, sir.
You've not examined the gait of the patient. How does he walk? Does he need support to walk? Can he walk on his own?
I have not seen. I didn't make him walk, sir. But
is it important
by
to know
history wise,
his gait? Is it important to know his gait?
Yes, sir.
Because, and why is it important to know his gait pre-operative before you do any intervention or any treatment?
Sir, if there are, we need to know whether he has any.
Okay, I'll tell you. Because if we know that his gait is sufficient enough to help him walk alone, any intervention can deteriorate his gait and he may require help. Right? Okay, you've not tested his joint movements, his vibration, sense of vibration, sensations. All this has been missed, isn't it? Hello, are you there, Dr. Sai? I think we lost her.
We'll allow a few minutes for her to join, sir. Please wait.
Right, sir.
Hi, are you with us?
Yeah, Dr. Sai?
Not yet, sir. Not yet, sir. She said to join, sir. Please allow her.
Okay. I mean, gait and the footwear of the patient is very important, especially in these cases, because if we have to do any amputation, we will have to know, because both the limbs, lower limbs are involved. He may require lots of support and help post intervention. I would just like to say that Burgess angle is not very important in case of patients with breast pain or ulcers, because any amount of elevation will cause pain. If it is lying flat and still painful, then any elevation. So in these cases, I think Burgess ankle is not very important.
It's a superfluous test, unnecessary test. With
Right.
other findings are there of Ishki
Right.
critical.
But for examination's sake, I mean, it can be asked, but it doesn't really help.
Other criticism of the test is the color of the patient also. Sorry to use that word.
Right.
We are dark skinned compared to the people who describe the test. So we might not get the classical findings in the Burgess
but
angle.
Sir, actually the dark skin, but the sole and the palm are similar colored, so you can get change in color there.
One more
but
thing,
yes, the whole limb color doesn't, you cannot appreciate it much.
Yeah, the test is incomplete because not only elevation, there should be a depression also.
Right, coupling of the veins.
Both the tests are there in Burgess test. Both components are there.
Right. In fact, for the postgraduates, they asked, why is the guttering of the veins? Because there is not enough return of the blood. There's not enough inflow of the blood. So the veins get guttered on racing. I think, is she there? I
think she's logged out and logging in again.
Okay. So I would just like to say that in peripheral vasculitis, it's most important to know, or in any limb disease, whether it's arterial, venous, or neurological. And that can be brief.
Back to this. I will try calling her.
I believe some examiner asked whether in these cases patients have impotence or erectile dysfunction. Is there any difference in that, sirs? I mean, there was an examiner who was asking about this. I couldn't find out the difference, so.
Sir, only give the answer.
Sai, are you there? I think she's Sai Vaishnavi.
I think Kanagwal sir is calling her.
Sir, she is just getting joined.
Yeah,
Sir.
she's
Yes, she is there. She is there. Connected.
There's a question for you, Ma. Professor Sahai will ask. Professor Sahai is asking you a question.
She's back, sir. Please continue.
right. Carry on, sir. I think I've done. I'm finished with it.
No, you asked a question, sir.
I don't remember what did I ask.
No, erectile dysfunction.
Did you get the ABPI in this patient? Have you done that?
Sir, I got the ABPI, sir. Not mentioned it.
Why you not mentioned that if you got it? That is probably
Yes,
one
sir.
of the most important part of the examination is there. That is probably, if you just give that information, we will be very happy.
Yes, sir. In the left lower limb, it was 0.7, sir. In the right lower limb, it is 0.8, sir.
Where you are not getting the dorsalis pedis as well as the posterior tibial.
Yes, sir.
How did you measure the ABPI in that patient?
The handheld Doppler, sir.
So in the handheld Doppler, you got some signals there?
Yes, sir.
Now, if you do not get any signals there, even on the Doppler, then can you do something else? If you really want to know that how much is the
Can measure the toe brachial index, sir.
toe pressure, right?
Yes, sir.
So how much is the toe pressure?
Actually, 70, sir. 70. Around 70.
So normally it's up to 70.
70.
Even if you do not have this, what is the relatively newer test which has come, which you can carry out just bedside? No, it has come in the COVID period. Now there are several studies and they are comparing this particular very easy test with the ABPI and other pressures.
Very household thing.
What is the test you do in the COVID? Whether you want to know the severity of the COVID?
Inflammatory markers.
No,
just the bedside. You have a small machine with you in your hand.
Maybe done by non-medicals as well.
Anyone can do it.
Sai Vaishnavi.
Sir.
Tiplo vanna veppa.
Very small instrument put on
Pulse
over
oximetry, sir.
Pulse oximetry.
Yes, sir.
So that is now almost replacing the ABPI.
Yes, sir.
And now there is a grading system for that also, which can tell you that your patient has got the ischemia or not. So that is coming out in a big way. Now, Sai, you palpated all the pulsations. Now tell, where did you feel for the dorsalis pedis?
Dorsalis pedis on the dorsum of the foot, just lateral to the tendon of extensor hallucis longus, sir.
Where? Which part of the foot you have felt that?
More proximally, sir. The first space.
It is in the first space, but where? You know, all the pulsations are felt against the bone.
Yes,
If you tell the name of the bone there, that you felt it against that, that will give you the location.
This is in the navicular.
Navicular and the middle cuneiform.
Yes, sir.
Where did you feel for the posterior tibial?
Midway between the tendo Achilles and the medial malleolus, sir.
Right. Against which bone?
So it is against the tibia, sir. Against the medial malleolus.
No, it is not against the tibia. It is against the calcaneus.
Okay, sir.
Where did you feel for the popliteal?
Popliteal can be done in two ways, sir. One with the patient in supine and knee flexed to 40 degrees, placing both the thumbs anteriorly over the tibial tuberosity and the four fingers posteriorly in the popliteal fossa between the two condyles of the tibia, sir.
Against which bone? Against which bone?
Tibia, sir.
Upper end of the tibia.
Yes, sir.
Where do you feel the anterior tibial? Against which bone?
Sir, against the lower end of tibia, sir. Midway between medial and lateral.
Lower end of the tibia. Okay.
Yes, sir.
Humeral pulsations?
Against the head of the humerus.
Head of the humerus?
Femur, sir.
Head of the femur.
Femur.
Radial artery?
Radial artery, sir. Radial artery between the tendon of flexor carpi radialis and the radial bones, sir. Against the radial bones.
No, against two tendons. Against the lower end of the radius.
Radius.
But what are the two muscles and the tendons there? One you rightly said flexor carpi radialis.
Radialis.
Another side is the brachioradialis.
Okay, sir.
And where do you feel the ulnar artery? Again, the front
flexor
of the
carpi. Lower end of.
Flexor carpi ulnaris.
Ulnaris.
Okay. Any other example? Dr. Mumtaz can ask you. Dr. Mumtaz is not asking. Dr. Mumtaz?
Yeah, what investigation would you do in this patient to confirm your diagnosis?
I think let us first have the diagnosis, Dr. Mumtaz.
Yes.
We still do not have the diagnosis.
Actually, she has already told that the diagnosis, but exactly what is...
Can you show the slide of the diagnosis?
Yes, sir.
So where is the slide of the diagnosis?
Yes, sir.
Go to that slide.
Yes.
Yeah. Tell your diagnosis.
Provisional diagnosis would be peripheral arterial occlusive disease affecting bilateral lower limb and the right upper limb with critical limb ischemia of the left foot, probably due to thromboangiitis obliterans, with probable femoropopliteal occlusion on the left lower limb and infrapopliteal on the right lower limb and infrabrachial on the right upper limb.
Do not give such a big diagnosis.
Okay,
diagnosis has to be very concise.
Okay, sir.
Just say that in 2 lines or 2 words that what is your diagnosis.
Is the name of the disease?
Thromboangiitis obliterans for Berger's disease.
Your diagnosis will be thromboangiitis obliterans or the Berger's disease.
Berger's disease, yes.
Yeah, which is involving both the lower limbs and also the upper limb also.
Upper limb, yes, sir.
Right. You want to give any differential diagnosis?
Sir, one differential diagnosis would be accelerated atherosclerosis, sir.
Yes. Or pre-senile, accelerated or the pre-senile type of atherosclerosis.
Okay, sir.
So how will you rule out that this patient does not have the pre-senile atherosclerosis? What are the points against that?
Atherosclerosis usually involves larger and medium-sized vessels, sir.
Right.
he can have, patient could be obese with
Yes.
um,
What other things which you
That-
can see in atherosclerosis? Yes. You said the patient may be obese, the patient may be diabetic also. Something
Yes,
around
sir.
the eyes, what can happen?
There can be arcus senilis, sir. There could be xanthelasmas in
Right.
the eyelid.
Xanthelasmas can be there. Yes.
Tendon
All those
xanthomas. Yes, sir.
Right. Now, from Mumtaz, you can take over now from the investigation.
Yes, what
may-
investigation would
sir-
you do to confirm the diagnosis of thromboangiitis obliterans versus the rapidly increasing atherosclerosis?
Sir, I would like to do blood investigations, sir. I will look for
Would it confirm the
hypercholesterol.
diagnosis? So you should say, what is the diagnosis, what is the investigation which can specifically confirm the diagnosis? Would blood investigation confirm the diagnosis?
No, sir.
So which investigation would you do?
Sir, I would do Doppler ultrasound along with duplex scan, sir.
Yes, very good. So what finding do you expect on duplex scan?
So there could be thrombosis. Thrombus can be seen, sir, can be visualized.
Okay.
In presence of
What
any
else?
collateral circulation, I can see, sir.
Sai, one question.
Yes, sir.
See, in Doppler, we
Yes,
describe
sir.
in terms of phasic.
Yes, sir.
Have you heard this word? Triphasic,
Yes, sir.
biphasic?
Yes, sir.
Waveforms.
Yes,
Yeah.
sir.
So go in that direction.
Um,
What phasic you will see, because you can't feel the pulses.
It
No? And you
could
have a
be.
gang.
It could be. I can see monophasic, sir, or a biphasic, sir. Monophasic, sir.
What else you will see?
What is the normal phase you see in the doctor?
Triphasic,
You
sir.
have to describe.
There is
It is
triphasic
triphase.
flows.
So what is that?
Triphasic.
What are those three phases?
The first is due to the systole, sir. First
Right.
upstroke. The downstroke is due to the diastole, and the third wave is due to the elastic recoil of the artery, sir.
Okay, so what happens in a case of if there is a vascular disease is there, what will happen? First, the
The
triphasic
second phase
will
is the
tri will
Sir,
become bi. No?
yes, sir. To become bi.
Become
The
biphasic.
second phase is lost, sir.
Yes. Yes. And then biphasic will become monophasic.
Yes, sir.
What will happen to the amplitude?
Amplitude will be decreased, sir.
So it will be gradually decreasing and becoming wider.
Okay, sir.
What do you understand by duplex scan?
Duplex, sir.
Uh-huh.
This B mode ultrasonography combined with the audio signals which we get on a Doppler scan, sir.
What is Doppler?
Sir, it is based on the Doppler shift mechanism, sir. The transducer sends the
So this
signals.
Doppler term which is there, is it some scientific term or
It's named after a
base city
person.
which is there or some person is there?
It's named after a person who
Is a surgeon?
found. No, sir, physicist, sir.
The physicist, right? He's a European physicist is there. On his name, this Doppler comes.
Yes, sir.
You know this Doppler principle which is there? Which animal uses to travel by this Doppler principle? Have you any idea about that? That which animal uses the Doppler principle for flying?
No, sir.
Related to COVID.
Dogs. Sir.
No, COVID.
COVID related animal.
The theory which was in the beginning.
Vaishnavi,
Sir.
you said Doppler Duplet is B mode and audiovisual, isn't it?
Yes, sir.
That is a wrong answer actually, okay?
Okay, sir.
Doppler Duplet means B mode, which is a grayscale image, and when
Yes,
you
sir.
use color on it, it becomes a color Doppler or a Doppler
Okay, sir.
Duplet. Color Doppler and Doppler Duplet are the same, okay? They mean
Okay,
the
sir. Okay, sir.
sound has got nothing to do with it, okay?
Okay, sir. Okay, sir.
Images, B mode is correct. We always use B mode Doppler, that
Yes, sir.
ultrasound, which is called as a Doppler when we use it for blood vessels.
Yes, sir.
And that comes as a grayscale, but it doesn't tell you anything.
Okay, sir.
Okay, if you superimpose color on it, you get some other findings. So
Yes,
together,
sir.
it's called as a Doppler Duplet.
Okay, sir.
Color
Okay, sir.
Doppler and Doppler Duplet are one and the same. Okay.
Okay, sir. Okay, sir.
There's a confusion. A lot of people answer this way, but this may be the. I don't know. The others you can chip in.
You know, my impression is B mode gives you the anatomy,
Yes, sir.
while the Doppler gives you the physiology.
Yes,
Okay, so if you want to trace an artery anatomically, that what is there, or if there is any stenosis present or not,
yes, sir.
then you do the B ultrasound.
Okay.
But if you want to see the flow in that, how much is the flow in that, that will be done by the Doppler.
Got it. Okay, sir.
Okay,
So
Vaishnavi,
one tells you the anatomy, another tells you the physiology.
Okay, sir.
just adding to the Doppler,
Yes, sir.
how do you identify that the vessel is an artery or a vein in Doppler?
Vein is easily compressible, sir.
No, now you are talking about the flow. So talk in terms of flow.
Okay, sir.
Flow, color.
Towards the if the flow is towards the probe, sir, it is usually red in color. If it is away from the probe, it shows a blue color.
Very good. So it's not the artery, actual artery and the vein, which is shown as the red and the blue. It is the transducer, the flow of the blood, which is going towards the transducer will be red, and away from the transducer will be the blue. So the same artery will be colored red or blue if you change the direction of the transducer.
Yes, sir.
Okay. So what is the principle behind this Doppler?
The signals from the transducer they hit the contents of the blood vessel like the RBCs, and the signals which the RBCs are produced are converted to audio, sir, and we are able to hear the.
So audio is just an addition, but basically it's the color which is there. Okay. So Doppler is based on the Doppler effect. So if you are the same which probably we have read in the physics. So if you are sending some waves towards a moving object, if the object is moving towards you, the wave length will change. So it depends whether it is moving towards you or away from you. That is why the color changes if you change the direction of the flow.
Okay, sir.
Okay. And how much the reflection is there? Okay, reflection tells you that what is the speed of that.
Okay.
You know, the animal I was asking about that was the bat. You know, bat travel in the night. They cannot see in the night, but they throw these Doppler waves and they can know that where is the wall in front. And those, it is reflected from that, and he calculates that, okay, just in front is the wall is there.
Okay, sir.
And very important thing, like in the cricket, you know, how do they know the speed of the ball, that this has gone 150 kilometers and it is 100 kilometers? This is with the Doppler.
Okay, sir.
Doppler is thrown in that, and you see that how much is the reflection from that, and that tells you the speed of that particular ball.
Okay, sir. Okay, sir.
Right.
Okay.
Mumtaz, you can carry
Sir,
on.
can I?
So after Doppler, what findings do you expect in thromboangiitis obliterans?
In Doppler, sir.
Yeah. Is it the medium and small arteries are involved? No?
Yes, sir.
So
Yes,
what
sir.
are you going to really see in those arteries? Is it only inflammation of the wall of the arteries or something else?
No, sir.
Yes, Dr. Sai.
The extent of the occlusion can be made out, sir. Presence of any collateral circulation, because it affects the medium and small size arteries.
So exactly what is the treatment you are going to intervene with? How do you decide that? Does this duplex scan guide you that what treatment would you offer to the patient?
No, sir.
So what are you going to do? What treatment are you going to offer to this patient?
Sir, I will initially try, because it affects the small vessels, surgical intervention will not be of much help for this patient, sir.
Okay.
I would like to start with conservative.
Dr. Sai, how do you know that your diagnosis is correct? How do you know your diagnosis is correct? How are you assuming there's just a small vessels involved?
I would like to go with another investigation, sir.
Yeah.
I will go for a CT arteriography of bilateral lower limb, sir.
So what is task 2 guidelines?
There are A, B, C, and D, sir. For it is different. It is for aortoiliac and femoropopliteal occlusions, sir. For femoropopliteal, A is it is a single segment which is less than stenosis, which is less than 5 centimeter, less than 10 centimeter, and occlusion which is less than 5 centimeter comes under A, sir.
Yeah,
sorry,
go
I'm
on.
not able to.
B is multiple, less than 5.
Yes, sir.
Or single stenosis less than 15. Or single stenosis, okay.
C is at the
more than 15 and more than 20, okay. Something like that.
D is more than 20 at the bifurcation, sir.
Right. So what do the guidelines tell you then?
What
do you do with A, B, C,
A and B endovascular interventions can be tried, sir. For C and D, surgical procedures like bypass can be tried.
Sorry, Dr.
Yes, sir.
Rahmani said that it doesn't seem to be a small vessel as the femurs involved. Was there any bruit?
No, sir. No, sir.
You didn't hear any bruit anywhere. Did
No,
you
sir.
try
No,
for
sir.
it? Did you
Yes,
look
sir.
for it?
Yes, sir.
Where do you look for the bruit? If there's a stenosis, where do you look for the? Where will you get
Sir,
get the bruit?
usually distal to the stenosis, we look for the bruit.
How
sir.
distal? How distal? Distal means suppose there's an obstruction in the femur. Will you get it in the middle of the thigh or lower end of the thigh? Just a
No,
couple of
sir.
centimeters.
It is just
Couple of
distal.
centimeters.
Yes, sir.
So have you got the CT report
Yes, sir.
with you?
Yes, sir.
Okay, go ahead.
Shall
Read
I
it.
put the report or the image, sir?
No, read this. No, don't go to read the angiogram. Okay, I think so. Saying that we close in 5 minutes. Quick.
Yes,
What do
sir.
you see?
Sir, on the right side,
Right lower limb, yeah.
right lower limb, there is no flow of contrast in the
No,
posterior
you can see the
tibial.
collaterals here.
Yes, sir.
You can see the collaterals lower below the legs,
Yes, sir.
right? So though they are less,
More over the left than the right,
but
sir.
there are collaterals developing even on the right.
Yes, sir.
So what will you know? What will your management be?
Management, sir.
Yeah.
Sir, first I would advise lifestyle modification, sir.
Very good.
Advise him to
What
stop
do you mean by
smoking.
life? Or you tell him to stop smoking, he'll stop smoking. He won't listen to his wife, he'll listen to his doctor. How do you ask him to stop smoking? How do you get him to stop smoking?
Any the de-addiction.
Okay, one is de-addiction. What else? Nicotine patches.
Yes, sir. Drugs.
Ask him to smoke half a cigarette and throw it away. These are the ways.
Okay, sir.
Okay, what else?
Sir, any exercise programs for him, sir?
With ulcers, would it help? Collaterals, okay, some collateral, but more important, come quickly.
Drugs, sir. Drugs like
which drugs? Quickly.
Antiplatelet drugs, like aspirin.
Which is the most
and
important drug
clopidogrel.
here?
Aspirin, clopidogrel, sir.
Yeah, very good. What else? Quick.
Drugs like silostazole, pentoxifilin can also be tried.
Yes.
Sir.
Sildenafil, tadalafil, phosphodiesterase 5 enzyme inhibitors. What else?
Yes, sir.
For his pain? Anything for his pain?
Pain can use opioids, sir. Or for if he has rest pain, so I would go for.
You can use topical
epidural.
nitroglycerin. You can use prostaglandin analogs. Okay, I'll give it to you. What about his ulcers? Good. Did he get an X-ray of his foot done?
I got. No, I don't have an image, sir.
Okay. Any osteomyelitis?
No, sir. There's no osteomyelitis, no gas shadows.
What will you do for his ulcer?
Sir, ulcer. I would go with conservative amputation, sir. Amputate only the gangrenous toes.
No. Do you have? Is it a dry gangrene or wet gangrene?
It's a dry gangrene, sir, which is.
But you said there's pus coming out.
Superadded infection, yes, sir.
How can it be dry gangrene if there's infection there?
Yes, sir.
So what will you do? How will you know? What will you do for that?
Investigation, sir.
Any-
Sir, I would do an X-ray of the local part,
That
sir.
you've done for the,
Yes,
for the
sir.
infection. For the infection.
I would take a wound swab, sir, for
No,
send
sir,
it for
you take a tissue culture.
tissue culture.
Swabs are not done. Okay, what
Okay,
else?
sir. I would go for
You have to convert the wet gangrene
debridement.
to dry gangrene. Now, how do you do that? One is by control of
Antibiotics.
infection. Second
Antibiotics,
is
sir.
improving.
Local debridement, sir.
Right. You have to keep that area dry. Right?
Yes, sir.
Right, and improve the circulation. Okay.
Yes, sir.
So where will it, suppose you do the patient's right limb has got poor supply. Suppose
Yes,
you do
sir.
an amputation. Will the thing heal or not heal?
It will not heal, sir.
So why will you do it then? It will heal. It's got good getting developing collaterals, so they're likely to heal.
Okay,
So
sir.
if you offload the pressure and keep the limb on rest,
Okay, sir.
then it will heal.
Heal. Okay, sir.
Right. Thank you so much. Okay, other drugs I'll tell you. Nifedipine,
Okay,
calcium channel blockers are used, right?
Okay, sir.
And
Okay,
sometimes botulinum toxin is also used for pain.
Okay, sir.
Faculty, any other questions?
I do know. Very important thing in a peripheral vascular disease is the revascularization, because
Yes,
that
sir.
is the most important thing.
Okay, sir.
Can you tell that what are the various ways of doing the revascularization?
Sir, endovascular procedures are there, sir.
The one is
Balloon-
endovascular. Just tell the headings.
Bypass procedures, sir, for more proximal and larger and medium-sized vessels.
Yes. Open techniques. Open techniques in place or extra anatomic techniques.
Okay, sir.
Right. Then endovascular techniques.
Stenting, sir, balloon angioplasty.
Angioplasty and the stenting can be done. Any other techniques which are also used, especially for the Burz's disease?
Sir, sympathectomy, sir, for relief of
In your
pain.
patient, that has been done.
Yes, sir.
Any other technique? You can do sometimes the omentopraxy can be done.
Yes, sir.
Or sometimes you can do the Eliza Rao technique, which is there.
Okay, sir.
Extraction technique. That is also one of the ways to revascularize that. And then the stem cells are there, which can be useful for them. So these are the other ways to do the revascularization.
Okay, sir.
Okay.
May I just add a thing, sir? In Burz's, you can increase the head pressure by diverting flow from the other limb if there's a single limb involved. So if the pressure increases, that helps in opening up the obstruction and the collaterals.
Okay, sir.
The people even have made AV surgery also. And extra anatomy bypass. Dr. Kanagal, can you finish at this time?
Do we have, Vaishnavi, do we have any questions to be clarified with the faculty? Any doubts you have, ma?
No, sir.
Okay, thank you very much, Vaishnavi. Faculty, Dr. Vivek sir, Dr. Mamta sir, any questions from any one of you, sir? Can we call this case a close?
Yes, sir.
Yes,
Okay.
yes.
Thank you, Dr. Sai Vaishnavi. You can stay with the session. We have one more
Yes, sir.
vascular case for this evening.
Okay.
Dr. Pooja, good evening. Can you switch on your PowerPoint, ma?
Yes, sir.
Kana, Sai Vaishnavi, you have to
Yes, sir.
unshare your screen.
Yes, sir. Yes, sir.
Thank you very much, Kana. Thanks to Dr. Madam, Professor Koperindevi ma'am, and Professor Kannan, sir. Good evening, Dr. Pooja. Welcome. Make it full screen, ma. Yes, you're good to go, Kana.
Good evening, everyone. I'm Pooja.
Switch on your video, doctor.
Pardon, sir. Sorry.
Can you switch on your video, ma? We are unable to see you.
Yes, sir.
Yep. Yeah, good to go, ma. All the best.
Yes, sir. I'll be presenting a case of 45-year-old male, resident of Doiwala, farmer by occupation. He presented with the chief complaints of intermittent cramping pain over the right calf since 4 months and blackish discoloration of the right foot since 1.5 months. History of presenting illness. Patient was apparently normal 4 months back when he developed insidious onset of right calf pain, which was cramping in nature and was intermittent with 2 to 3 episodes per week, which gradually increased to 5 to 6 episodes per week. It was non-radiating and it occurred after walking a distance of 100 meters initially. The distance decreased to around 20 to 30 meters after the onset of gangrene, which happened 1 month back. The pain stayed for around 10 to 15 minutes and was spontaneously resolved. He was on oral analgesics and there was no history of rest pain. In the last week of July, he developed blackish discoloration of the right foot, which was insidious in onset and progressive. Initially, it involved the toes and later progressed to the dorsum, involving the distal third of the dorsum of the foot. There was no history of the similar complaints in the other limb. There was no history of trauma. There was no history of blurring of vision, diplopia, blackouts, or altered sensorium. There was no history of chest pain, shortness of breath, orthopnea, or palpitations. There was no history of any postprandial pain, abdomen, vomiting, or weight loss. There was no history of impotence or pain in the lower back or the gluteal region. Past history, there was no history of any ischemic heart disease. There was no history of diabetes, hypertension, TB, prior surgical interventions. There was no personal history. Patient was consumed a mixed diet, vegetarian diet. He was a chronic bidi smoker, smoking 10 to 12 bidis per day since 15 years. He had normal bowel and bladder habits, and sleep was disturbed due to pain. Family history, patient was married since 16 years with 3 healthy children, and there was no history of similar complaints in the first degree relatives. To summarize, it's a case of 45-year-old male, a chronic bidi smoker who presented with intermittent claudication since 4 months with blackish discoloration of the right foot since 1.5 months.
Pooja,
Yes, sir.
can you go back to your negative history? Can you explain why did you take each of these negative histories?
Yes, sir. Sir, history of similar complaints to the other limb to rule out a proximal spread of the disease as seen in atherosclerosis, which spreads proximally to distal. So there were no history of complaints in the other limb. It was
So you suspect atherosclerotic disease in this patient?
No, sir. But there was no history in the other limb.
Okay, go ahead.
There was no history of trauma.
Okay.
Secondary to which there would be a blackish discoloration to the foot. And so there was no history of blurring of vision, diplopia, blackouts, or altered sensorium to rule out any ischemic disease, any transient ischemic disease or strokes.
So in which condition all these negative histories they stand important?
Certain cardiac diseases.
Which disease of peripheral vascular disease group?
So atherosclerosis.
Okay. And what's your suspicion based on history?
Sir, since patient is a young male who's a chronic bidi smoker, most likely the diagnosis is Berger's disease.
So what is the incidence of having a ischemic heart disease in a patient of atherosclerotic peripheral vascular disease? How much is the risk increased as compared to a normal population?
Sir, there is 30% people with ischemic heart disease have 30% chances of having a peripheral arterial disease.
Can you answer it in terms of a relative risk, or how much more they are at risk of ischemic heart disease as compared to normal population?
So, so twice the risk.
It's almost in the tune of 4 to 5 times. Why did you take history of abdominal pain?
Sir, to rule out mesenteric ischemia, which would result in postprandial pain abdomen and associated weight loss, because the patient would be taking less meals due to the severe cramping pain associated in mesenteric ischemia.
What type of mesenteric ischemia it would be?
Sir, venous mesenteric ischemia. Chronic.
Venous. In atherosclerotic, you find a chronic venous mesenteric ischemia.
It's a chronic arterial mesenteric ischemia.
So, what will be the typical characteristic of pain for that?
Sir, cramping pain. Postprandial cramping pain.
And along with pain, what will the patient have other symptoms like?
Sir, vomiting.
Okay, it would be like passage of red currant jelly type of stool, because of the mucosal shedding.
Okay.
Okay, any other questions from other examiners?
In that mesenteric ischemia,
yes, sir,
there will be a lot of symptoms, but very few signs.
Yes.
That is one thing you have to be aware. Because
Right.
even cardiac disease, even coronary artery disease can have pain abdomen. Okay, as a presenting symptom. Of postprandial pain abdomen is the commonest way coronary artery disease is diagnosed. Okay. The signs are out of proportion to the symptoms. Symptoms are more in mesenteric artery syndromes, mesenteric artery ischemias rather.
Right, sir.
So what do you think on your history? What do you think is your diagnosis?
Sir, I think it's peripheral arterial occlusion disease involving the unilateral limb in a young male patient who's a smoker. Most likely the disease is Berger's disease.
What is the justification? I mean, although you're not examining the patient, based on your history, how do you justify that diagnosis?
Sir, age of the patient, less than 50 years. Then history of smoking is present. Then, sir, it's infrapopliteal occlusion.
How do you ascertain that it is infrapopliteal?
Sir, first there's he has pain in the calf region. The claudication pain is limited to the calf region, and so that's how I assessed the level of arterial block.
Thank you. There's no rest pain, isn't there?
There's no rest pain, sir. I've taken the history of rest pain.
There is a gangrene and then there is a claudication, isn't it?
Yes.
Can you tell what are the vascular causes for the abdominal pain?
Sorry, sir.
What are the vascular causes for the abdominal pain?
Sir, it can be acute arterial mesenteric ischemia, or a chronic arterial mesenteric ischemia, or a venous mesenteric ischemia. So acute will be due to embolus. A chronic will be due to a long-standing thrombus formation in the mesenteric arteries. And apart from that, the vascular causes can be due to abdominal aneurysms and dissections, aortic dissection.
basically you can divide these causes into, just like in a case of the bowel, we say it is a intraluminal cause, or it is a intramural cause, or it is extramural cause. So what you have described, like there's a thrombus is there, the embolism is there, that is intraluminal. If there is atherosclerosis is there, or dissecting aneurysm is there, that is the intramural. But can you tell what are the extramural causes for the abdominal pain?
So any tumor compressing on the,
Okay, one is tumor, yes.
sir, any
congenital anomalies which can cause the pressure over the extra
sir, coactation,
causes.
the coactation, aorta causes.
Coarctation will be in the wall. Coarctation will be in the wall. I'm asking the extramural causes. Something pressing from outside.
So one is tumor.
Yes.
And sir, lymphadenitis, sir, enlarged lymph nodes compressing on
any space of occupying lesion, and any which can be in the lymph node, or it can be in any bowel or the pancreas or anything. Anything else?
Sir, mass effect.
Okay, I will just give the superior mesenteric artery. Okay, that is one. And another is the median arpit ligament syndrome, where there is a median arpit which is compressing over the celiac axis, and that can present like a abdominal angina. I think you can go ahead with the examination now.
Do you know the sign of median arcuate ligament on CT scan, doctor?
Not sure, sir. Yes, sir.
Okay. Fish hook sign.
Fish hook sign. Okay, sir.
Tell about the examination now.
Yes, sir. Examination. Patient was conscious and oriented. He was well hydrated. His BMI was 19 kgs per meter square. His pulse was 80 beats per minute, regular rhythm with normal volume and normal character. Condition of the vessel wall was normal. There was no radial or radiofemoral delay. BP was 130 by 70 mm of mercury measured over the right brachial artery in supine position. Patient was afebrile and had pallor. So moving to the local examination. First, the left lower limb, which was the normal limb, there were no skin or nail changes. There were no discoloration. The sensations were intact, and active and passive range of motions were within normal limits. The length and the attitude of both the limbs was same. The muscle bulk, the calf region measured was the right was 8 inches and left was 9 inches. Coming to the affected lower limb, which was the right lower limb. On inspection, the skin was dry with loss of hair and nails were brittle with transverse ridges. The toes were shriveled and mummified. There was a gangrenous area over the right foot involving all the toes and covering both the distal and the dorsal aspect, plantar aspects up to the distal third of the dorsum of the foot. Sorry. There were well demarcated margins at the toes. The active toe movements were absent, and there were no discoloration proximally along the veins. Berger's test could not be elicited due to the dark complexion of the patient, and the Fisher's test, the oscillatory movement was absent. This was the image of the affected foot. Here we can see the mummified and the shriveled toes with well demarcated lines, and the proximally there was edema and erythematous patch over the dorsum. On palpation, there was decreased local temperature compared to the contralateral limb. There were no sensations up to the metatarsophalangeal joints. There was pitting edema present proximal to the dry gangrene of the toes up to the distal third of the foot. There was no crepitus. Capillary refilling could not be elicited. Power at the ankle was 2/5 and distally it was 0. Venous refilling time was delayed. Peripheral pulses, the right lower limb the dorsalis pedis artery, anterior tibial artery, the posterior tibial artery were all absent, and popliteal artery was feeble. And whereas the right femoral artery and all the other arteries in the left lower limb were felt properly. The radial, brachial, and the carotids bilaterally were normal, and there was no bruit heard. The systemic examination, there were no murmurs heard, and the heart sounds were normal. The rest of the systemic examination was within normal range. To summarize, this is a case of 45-year-old male, a chronic smoker, presented with intermittent claudication over the right calf since 4 months, associated with blackish discoloration of the right foot since 1 month. He had pallor with dry gangrene of the right foot, with associated loss of pulses distal to the femoral artery in the affected foot, with all signs suggestive of chronic limb ischemia, most likely cause being the Berger's disease.
Pooja, did you do the ABPI in this patient?
No, sir, I didn't do the ABPI because it needed a Doppler, and so it wasn't working in the
Doppler means handheld Doppler.
handheld Doppler. Yes, sir.
So apart from the handheld Doppler, what else do you need to look for the ABPI?
Sphygmomanometer, sir.
So you don't have a sphygmomanometer?
So we do have it. But sir, to localize the dorsalis pedis and the posterior tibial artery for the ankle pressure.
So the same sphygmomanometer you use for measuring the brachial and the ankle pressure both?
No, sir. Smaller cuff is used for the ankle pressure. Measure the ankle pressure.
How do you ascertain the size of the cuff?
So for ankle, I'm not sure.
So normally it depends upon the diameter of the limb, like pediatric, adult, the sizes differ. So it depends upon the diameter of the limb. The cuff should be at least more than almost nearly 1.75 to 1.8 times the diameter of the limb. Then only it can be, and it has to be snugly wrapped, and you have to have a handheld Doppler. Suppose you had a handheld Doppler and a adequate sized cuff. So would you like to measure in this patient when the dorsalis pedis and the tibial arteries are not palpable?
Sir, no, sir, we wouldn't have gotten the pressure because using a handheld Doppler, yes, sir, to rule out acute limb ischemia.
No, you don't. Suppose you are not having a palpable vessel and there is a gangrene.
Right, sir.
So what would be the use of that handheld Doppler and that adequate sized cuff?
So we can measure the.
Still, you can measure it on the affected limb, but the other limb you have to measure. The other limb which is there where the pulse is palpable, still you have to measure the ABPI in the apparently normal limb.
Pooja, I have a question.
Yes, sir.
Yeah. Why do you need a Doppler? I mean, is it an absolute necessary or no? If the answer is yes, why? If the answer is no, why not? You understood my question, no?
Yes, sir. To measure the ankle.
Why do you need the Doppler? Why you can't do it with the sphygmomanometer, with the stethoscope?
So it won't be heard in already occluded arteries.
No. What is the reason why we have to use a Doppler? Suppose the ABPI comes as 1.3. Is it normal or abnormal?
So it's normal.
1.3. What is a normal ABPI?
0.9 to 1.3.
So above that, above 1.3?
Sir, it's seen in patients with diabetic nephropathy and end-stage renal diseases. And
Why is it higher in them?
Calcified vessels, sir.
So therein lies the answer for your using the Doppler.
Okay, sir.
If you use a BP cuff a regular BP cuff and a stethoscope without a Doppler on a calcified vessel or any stenosed vessel, you will get an erroneously higher value. Okay. So to know exactly where it is, you need the Doppler, the unstenosed part. Okay.
Right.
Now in a gangrene, what would be the ABPI when there is an obvious gangrene?
Sir, less than 0.3.
Okay. You said you did the Burgess test, no? Coming back to one of your tests, you didn't do the Burgess test because of complexion. Okay.
Yes.
Did you not need to do it at all with the gangrene being there? Why is the Burgess test done? And what is your interpretation of the Burgess test? We had discussed it in the earlier case also. Probably if you had listened to it.
Sir, basically to know the severity of the insufficiency of the disease, basically.
There is a gangrene, no, Pooja? So
yes.
What do you think? When there's a gangrene, what is that called? When there's a gangrene in a chronic limb ischemia, what is that called?
Sir.
See, is it critical limb ischemia already?
Yes, sir.
Is it
yes.
simply ischemia?
Yes, sir.
So the Burgess test is superfluous. It's a test for the sake of doing the test. It doesn't give you any information. When you're going to do the Burgess test is people with symptoms, but no signs.
Right.
When there are vessels palpable, early cases which we don't get in India, unfortunately. Most of our cases come with gangrene. Okay, the patients ignore the symptoms or they come in gangrene. So these tests they're described in the book, but seldom we get to do them because patients come in the late stages. Okay.
Right.
It is not the complexion. Okay. It is the gangrene which is preventing you from doing it.
Right.
Yeah.
Okay, Pooja, just in continuation to the ABPI, suppose the ABPI is more than 1.3.
Yes.
And there is no gangrene. So how will you ascertain whether the vascularity is compromised or not?
Sir, we'll check for the ankle brachial pressure after exercising, after making the patient do a strenuous workout or activity.
So what will happen?
Sir, in a normal individual,
No. If the ABPI is more than 1.3.
Yes, sir.
Then how will you ascertain? And you suspect that there is calcification of the vessel walls because of the age or atherosclerosis of the patient?
So we make the patient exercise, and if there's a reduction in ABPI less than by 0.1, then.
So do you suspect in a calcified wall to fall after exercise?
No, sir.
When there is a ischemia, already the ABPI is coming high.
Yes, sir.
So here comes the indication of doing a toe brachial index. This is the indication of doing a toe brachial index. So now comes the question, how will you do a toe brachial index? What instrument do you need for that?
Sir, we use a sphygmomanometer only to see the pressure at ankle and at the toe.
No, it is the toe brachial. So for the brachial, you use a sphygmomanometer cuff, and for the toe,
So there's plethysmograph.
yes. It is not with a sphygmomanometer, but it's by a photoplethysmograph that you measure. Okay, so the indication of doing a TBI is when the ABPI is more than 1.3, but you are suspecting a ischemia in the patient. It must be there because there are calcific walls. Okay.
Can you tell what is the audible sound you hear in a handheld Doppler from the artery and from the vein? What type of the sound you hear?
So
If you put your probe over the artery and if you put a probe over the vein, what type of the sound you hear?
So high amplitude, high amplitude in case of arteries and low amplitude in vein.
But what do you hear?
So the
You hear the sound whoosh, whoosh. It is a whoosh sound which is there in the artery. And in the vein,
so
what type of the sound you hear?
So low intensity.
It is the low intensity, just like if an earthquake has come. If you can imagine that the earthquake is coming, there's a very fast air which is coming. The type of the sound which is there, that is on the venous one. Okay. So in the arterial, it's the whoosh type of the sound, and in the venous, it is the earthquake type of the sound you hear. Now tell what is the difference between a Doppler and between a plethysmograph? What do you see on a Doppler, or what do you calculate the value on Doppler, and what do you calculate the value on the plethysmography?
So plethysmography tells us about the pulse volume, and sir, Doppler.
Not the pulse volume; it is a volume in the
different segments of the body.
In the tissue which is there. Okay, amount of the volume of the blood in the tissue which is there.
Yes, sir.
And the Doppler will tell you about the flow of the blood. Okay. So one tells you about the flow and other tells you about the amount of that. And that is why in the toe pressure when you are taking, because you are putting a very small cuff there, or you are putting the certain type of the waves over that, like the laser you can put the infrared waves over that, and you calculate that how much is the total volume of the blood in that, and by that you calculate it.
Right.
Any other investigations which are done apart from the duplex scan, the CT scan, plethysmography, any other investigations which can be done for the vessels?
Sir, magnetic resonance angiography.
Various type of angiography. So tell what are the various type of angiography?
Sir, CT angiography, MR angiography, then sir, carotid angiography, digit subtraction angiography.
Right. What is the classical angiography? When all these things were not there, what was that called as?
So coronary.
Not for the heart. We are talking about the peripheral circulation. When you are doing any procedure,
Yes.
therapeutic one, what you do? Any therapeutic procedure which is there.
Yes.
You know what is the technique which is used?
So instilling the contrast and then taking the images.
So what is that technique called as? The majority of the time to see for any peripheral vascular circulation, you will do the transfemoral angiography, and the classical it is called as the Seldinger's technique.
Seldinger's. Okay.
Seldinger's technique.
Guide wire.
And that is the way, any therapeutic procedure. And you can go through the brachial artery also, you can, but majority of the time it is the transfemoral which is done. So the type of the angiography will be a Seldinger's type of the angiography, CT angiography, MR angiography, DSA. Okay.
Right.
And what are the types of ultrasound which can be done for the blood vessels? One, you can do the duplex scan.
So then spectral Doppler, and one is
that is from the surface, na? Can you do something inside the vessels?
Sir,
You can do an intravascular ultrasound.
right.
Okay, so you go inside the vessel, which can be done both for the arteries as well as for the veins also. So that is the intravascular ultrasound.
Right, sir.
Okay. Then you can do the certain type of TAT studies, like the RBC stats, nuclear studies which are there. You can carry out those studies also. Okay, so these are the other techniques which can be done, but majority of the time, these techniques are not done. Only two relevant techniques which are there that you have to carry out the duplex scan for that. And second is, if you are planning for any intervention, you will go for some type of the angiography. And now, if you are doing a therapeutic one, then you go for the Seldinger's technique, but only for the diagnosis purpose, you only do for the CT angiography or MR angiography. Do you know what is the type of the things which can be used for angiography? What dyes can be used for that?
Yes, sir.
What are those?
So they can be ionic dyes and non-ionic dyes. Generally, non-ionic dyes are preferred because they are less toxic, like ioxol. And so we can use carbon dioxide and gadolinium in patients having already like renal diseases to prevent nephrotoxicity.
So you either do a classical type of the ionic or the non-ionic dyes for that. But if the patient's renal compromise is there, you can use the CO2 angiography for these patients. Or you do the MR angiography for these patients.
Yes.
Okay. Right. So what has been done in this patient? What investigation has been done in this patient?
So a duplex scan has been done for the patient, which was suggestive of absent flow in the dorsalis pedis, anterior tibial artery, posterior tibial artery, and biphasic flow in the popliteal artery, with triphasic flow in the popliteal artery and all the other arteries of the contralateral limb.
Angio has been done?
No, sir.
Angio is not. So how did you manage this patient?
So first, the basic diagnostic workup, which involved the duplex scanning, confirming the clinical diagnosis. Then, sir, the baseline investigations. We checked for the sugar levels. Then, sir, the lipid profile. Then, sir, a cardiac workup, including a 2D echo. Then, sir, X-ray of the foot to rule out any osteomyelitic changes or bony erosions. And
What
sir,
other things you can see on the plain X-ray of the foot?
So bone erosion, osteophytes, or any fracture, any pathological fracture.
Anything else regarding the vessels?
Calcified vessels.
You can see the calcified vessels. Okay, so if your Doppler is giving or the ABPI is giving, it is 1.4, and you will see on the X-ray of the foot that there is a calcified blood vessel.
Right.
Yes. Then what you will do?
Sir, so that's it for the investigations.
Okay. So this patient is a non-diabetic patient.
Non-diabetic patient.
And there is a infrapopliteal block in this patient is there.
Yes, sir.
How is the appearance of the CT angio in a case of Burz's disease? How does that look like?
So the corkscrew appearance.
Corkscrew appearance, right. Now, what is the most important thing you see on a CT angio in a case of a vascular disease?
So CT angio, we see the length of the segment involved.
Right.
The number of segments involved.
Yes.
The information of collaterals, if any.
If you remember in the last case, have you seen that film in the last patient?
Sir,
do you remember that?
No, sir. I don't know.
Okay. So one of the very important things you have to see for that how much the distal flow is there. That is one of the. So you have to look both for the inflow and for the outflow.
Distal
And
runoff.
your inflow, it has to be also good as well as outflow. So in the last picture, what in the last patient, it was being presented by the other girl. Okay. On the right side, we see that there was no distal flow was there.
Right.
The inflow was there, but there was no distal flow. So once there is no distal flow is there, then in that case, it is not good to carry out any type of a revascularization procedure. Until and unless the vessel is reformed, you have to be sure that the patient's distal foot is being supplied with the blood vessel. If it is not being supplied with a blood vessel, means from the natural blood vessel, natural collaterals which are there, then if you carry out any procedure in these patients, it will be not help. So that is one of the very important things that you have to see both for the inflow as well as for the outflow which is there.
Right.
Okay, so what can you do for your patient?
Sir, we can go for a conservative amputation.
Okay.
In this case, sir, we did.
So you will directly go for the conservative amputation in this patient? You do not want to try any medicines directly in amputation? Amputation is the failure of your, what we call it is a failure. So amputation has always to be avoided as far as possible. So before you go, like in this patient,
Yes, sir.
Still if you give certain medication in this patient, there may be some improvement may be there. And probably you can just limit your amputation only to just the tip of the toes only.
Yes, so like
so what medications can be given, and which is the most important medication nowadays for the peripheral vascular disease?
So vasodilators.
No, tell the name, nothing like the vasodilators. Tell the name of the drug, which is the most important one.
Vasodilator.
Pooja,
Yes.
before we go to the medications,
Right, sir.
what will be the level of you offered amputation, isn't it?
Sir,
you offered so you said you will go ahead with amputation. Am I, if I heard correctly?
Yes, sir.
Yeah. What will happen? What will be the level of your amputation in this patient?
Sir, below knee amputation, because sir, there is no flow in the foot, the anterior tibia artery, posterior tibia artery, and the dorsalis medius. The flow is compromised in all these arteries. So doing a forefoot amputation will not benefit the patient.
No, you use the word conservative amputation, isn't it?
So like not for this patient, for like sir, in cases of Berger disease, we generally go for conservative amputations.
No, I'm talking of this patient. I mean, the patient is there, right in front of you.
Yes, sir.
So what do you mean by conservative amputation and what do you mean by normal amputation? What is the difference between the two?
So conservative amputations where, sir, we are not, like in this patient, we will start initially with a forefoot amputation.
So is that conservative amputation?
So considering all the toes are gangrenous, and a normal amputation would be the one involving
no, conservative amputation is the where you don't have to disarticulate, you have to not have to amputate the whole of the forefoot, either a couple of digits or this thing, because if you remove the whole forefoot, the patient has a tendency to fall forwards. He'll not be able to walk.
Yes, sir.
He'll just be able to use it as a step toe, isn't it?
Yes, sir.
So that's not conservative. Look, in any amputation, which is in a foot, the best way to amputate is below knee, even if it is involving the foot.
Right, sir.
Why?
So prosthesis, the patient.
First of all, healing is will be assured of healing, and second would be prosthesis. Okay. Do you know about angiosomes? What are angiosomes?
So angiosomes are the areas of the foot which are area which is supplied by the same vessel.
Okay. So which angiosomes do you think are involved here now? Which vessels?
So
according to the picture, which angiosomes, which vessels are involved?
So which
vessel is not involved probably then?
So the heel is not involved. So the
So that is supplied by?
peroneal, so the lateral peroneal artery.
Right, the peroneal artery.
And the posterior artery.
So which are the two angiosomes that are involved? How many angiosomes in the foot?
6. So 6.
There are 3. Having 3 for posterior tibial, 2 for anterior tibial, and 1 for peroneal. And 1 for anterior tibial and 2 for peroneal. Okay. So,
right.
So which are the angiosomes involved now?
So the anterior tibial
and the posterior posterior tibial. Okay.
Right.
So if the 2 major vessels are involved, we can't go in for a conservative or amputation of the forefoot. Okay?
Right.
Go ahead, Pooja. Dr. Khanna's questions.
Yeah.
Medications.
Yes, sir.
So Dr. Khanna sir was asking, no, medications.
Medication, yeah.
Phosphodiesterase inhibitors, silistazole, to prevent the platelet aggregation. That's the most commonly used drug.
One of the best medication which is available is the silistazole. Okay. Pentoxifylline has gone into a big debate now whether it should be given in the peripheral vascular disease or not. But silistazole and the antiplatelet drugs which are there, these are the 2 main. There are so many which are there. You can use the vasodilators, you can use the vasoconstrictor, nicotine, and all those are the drugs. But the main drugs which are there is the silistazole and the antiplatelet. Where is the ecosprin or the aspirin, which is there, is one of the most important. You can give the dual antiplatelets for this. And then you can try for certain, like iloprost is there, okay, which is a type of in these type of the limbs where still it is not a completely gangrenous limb. Okay, it is on a progression of that. So you should try in this patient to give certain medical treatment for this. You can try for the patient giving the low molecular weight heparin to these patients. You can give the patient the dextran to this patient, and probably there may be a distalization of the gangrenous part may be there. And ultimately, you may not have to land into the below knee amputation, but just the digital amputation may have to be done in this patient. Okay, so do not jump over the amputation for these patients. First, give the patient a good medical treatment, and then you go and try for that. Now, tell what are the various types of the, in fact, we have discussed in the last one, what are the various types of the options which are there to revascularize this limb?
Sir.
Okay, I think we have discussed that in the last class. Let us discuss something about the lumbar sympathectomy. You know how to do the lumbar sympathectomy?
Yes.
What are the various ways to carry out the lumbar sympathectomy?
Yes, sir.
Tell.
Chemical sympathectomy.
Good.
And sir, open method to just remove the ganglions. So
you can do the open one. You can also do the laparoscopic one. You can do the retroperitoneoscopy can be done for that. Or you can do the chemical, any other RFA, radio frequency ablation can be done for that. Now tell about the open one. Will you do a unilateral or bilateral?
Sir, it's done bilateral, saving unilateral L1 ganglion to prevent impotence in males. So
and how many ganglions are removed?
Sir, L1, L2, L3, L4.
And if it is bilateral, you will save the L1 on one side.
Yes.
Okay. Now tell what are the various structures which you can confuse with the lumbar sympathetic chain?
The lymphatics.
Lymphatics one, yes. What else?
So
the other structures which are there is the any nerve there in that area?
The genitofemoral.
Yes. Genitofemoral nerve. The lymphatics and the lymph nodes which are there. Sometimes the ureter can be confused with that. And strip of the psoas minor. Now, if you are given a choice to carry out a sympathectomy as a surgeon on right side or left side, which one you will do?
So the right side.
Why right side?
So on the left we'll have aorta. So to prevent arterial injury.
On the right you will have?
The inferior vena cava, and the left will have.
So between these two, between the aorta and IVC, which one you think is more dangerous?
Damaging the aorta.
Difficult to control if damaged.
Yes, sir.
Which is more difficult if damaged, and which is more damaged?
Sir, aorta, the pressure of the bleeding will be difficult to manage to stop.
The wall of the aorta is so thick, IVC is so thin.
Okay.
So it is always the surgeon is more worried from the IVC bleeding rather than the aortic bleeding.
Okay.
And second thing is, what is the relation of the sympathetic chain to the aorta and to the IVC?
So they lie between the IVC and the aorta, between the psoas muscle.
Now, what is the relation on the right side and on the left side?
So
on the left side, this is para-aortic. Okay, so this will be lying on the side of the aorta, not on the aorta or behind the aorta, while on the right side, it is retrocable. It is behind the IVC. So IVC being a more dangerous structure is wall structure, and here the sympathetic chain is lying behind the IVC. So you have to dissect the IVC to find out the sympathetic chain. And that is why if you are given a choice to operate right or left side, you will say that I will operate on the left side and not on the right side.
okay.
Okay. How much is the length of the sympathetic chain which is removed approximately when you are doing a lumbar sympathectomy? It's around 10 centimeters. Okay, approximately 10 centimeter length is removed. Now, how do you know in the post-operative period that you have done a good sympathectomy?
When there is a patient will be relieved of his symptoms.
No, but that you are giving the patient analgesic anyway. So the patient will be relieved of the pain because of the analgesics. But how will you know your sympathectomy you have done is a good one?
What is Brown's vasomotor index?
Sorry, sir, pardon?
Brown's vasomotor index. That's what sir wants to know. Next morning, you come, you have to, your boss tells you whether he's done a good job or not. What will you do next morning after the surgery, post-op day 1?
Sir,
You've seen, I don't know whether it's done or not, you've seen residents carrying buckets of warm water.
Sir, the temperature of the limb will be more. So like compared preoperatively.
You just, Pooja, you just, when you go for the evening rounds, put your back of the hand over the limb.
Yes, sir.
Which you have done before that it was cold. Now it is feeling warmer. So if it feels warm, it means you have done a good job. But if it is still the same temperature is there because before, then probably you have not done a good sympathectomy.
Right.
Actually, after sympathectomy, the temperature will not move up or down. So if you dip the normal limb in warm water, the temperature on the side where the surgery has been done will remain the same. It will not rise or fall. Right?
Yeah.
While the limb on the other side will rise.
Right.
Can I ask you a few questions on amputation? What are the indications for amputation?
So death of the limb.
Okay.
Which is basically the gangrene. So,
okay.
Sir, any disability.
Okay, dam nuisance.
Damage. Then, sir, sir, deadly limb.
Right. Like?
Sir, having osteosarcoma.
Okay, malignancies.
Or trauma with comminuted fracture of the.
Okay, crush injuries.
Crush injuries, sir.
Okay, so it's deadly, dying, and dam nuisance.
Yes, sir.
Okay. Now in this patient, will you do a single stage or a two-stage amputation? What is the what is the advantage or disadvantage of a two-stage or a single-stage amputation?
Sir, in single stage, we do the stump closure along with the amputation, and two stage, the stump
No,
closure.
this is a patient with ischemia. Will you do a single stage or a two-stage? Below knee.
So two stage.
Why?
So considering the popliteal flow in this patient is feeble and was biphasic, so we're not sure of the vascularity of the.
Right. You don't expect a primary healing. Very good.
Yes, sir.
Okay. So what kind of what is myodesis and myoplasty?
Sorry, sir.
What are the two types of flaps used? Myodesis and myoplasty. What are the difference?
Sir, one is the U-shaped flap.
No, you taken a U-shaped flap here. But what is myodesis and what is myoplasty? So let's get that, and then get to the flaps.
Sir, in myodesis, the muscles which we transact, they are stitched to the bone which is underneath.
Right, very good. And myoplasty?
And sir, myoplasty, when the muscle is sutured to the soft tissue.
To the periosteum or to the fascia, the opposite muscle.
Yes,
so
sir.
in ischemia, which one is done? You do a myoplasty or myodesis? Or infection?
Sir, we do we stitch it to the bone.
No, we don't.
Okay, we
soft tissue. We do a myoplasty. We don't do myodesis. Because if there is ischemia or infection, it will result in osteomyelitis. Okay.
Okay, sir.
Okay. So what kind of flap do you use? Anterior flap or a posterior flap, and why?
Sir, a posterior flap.
Why?
It has a rich vascular supply and it's thick. It is thick and
flexor areas are always better supplied. Okay. What else? What else? The patient will be able to see the suture line.
Yes, sir.
Right. And the weight bearing portion will be posterior, is usually posterior. So we don't want the weight bearing portion to be over the suture line. Okay. Okay, but how will you know that your scar will heal? By what tests? Any tests for it? It's basically theoretical. I don't know how to do it. Skin perfusion. More than 20 millimeters, there's 90% chance. More than 30 more than 30 millimeters, it's almost 100%. Okay, very good. Well done for you. Should I ask you something more? What is the difference between below knee amputation and above knee amputation? How will you know what's the difference between the two? Pooja, are you there? I think she's gone.
Okay, no, I think she disconnected, sir. I think.
Okay, I'll just say in below knee, the patients will never require a crutch or a stick. Above knee, they always require a stick. Like Sudha Chandran, she had a below knee and she could dance. So a person with above knee will always require some support, some sort of support. So we always prefer a below knee. That's why. And a below knee can use a suction cone. So you don't need straps and all to hold the processes together. In upper knee, above knee, we require some contraption to hold the prosthesis. I think she's gone.
Yes, sir. Sorry.
You there?
Yes, sir.
Could you hear what we discussed?
No, sir. Sorry.
Okay, so what is the difference between a below knee and above knee amputation?
So, like the indications.
No. What is the difference? Basic difference. Suppose you have to offer a patient he can do with a below knee or an above knee. Which will you do and why?
Sir, a below knee amputation.
Why?
The knee stump is well supplied by the blood supply is good of the.
Even above knee is better supplied. You got thicker vessels, larger vessels, better supply. In fact, healing at above knee is much more than, it's almost 3 times more than below knee.
The prosthesis.
Yeah, what about the prosthesis? Look, below knee, the patient can walk without any support. It doesn't require a walking stick, doesn't require a crutch. Above knee, they will always require a walking stick or a crutch, right? And below knee, you can use suction stumps. So you don't require any contraption to hold the prosthesis. While above knee, you will always require some contraption to hold the prosthesis in place.
Right.
So even if because healing is better in above knee, we still prefer a below knee. So,
can you tell what are the basic differences between carrying out the amputation for a vascular case and for a non-vascular case?
Sir, so the differences.
Yes.
Sir, in vascular cases, we'll be always be worried about the supply to the stump. So we'll keep that in mind while performing the amputation.
That you have to keep in anyone, whether it is a vascular or non-vascular. But what you do in the vascular case and what you do in the non-vascular case. Or other way I say, what you do in a non-vascular case should not be done in a vascular case.
Do some contraption in a non-vascular case while amputation, which you don't in a vascular case. Pooja?
So, yeah, can you repeat your question? Sorry.
Like someone was asking, what do you do? What do you use? What do you don't use in a vascular case while amputation?
Now, before you start your amputation, you ask your floor person or the paramedical who is ever there that put this one on this. What is that?
The application of tourniquet.
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 So in a case of vascular one, you will never put a tourniquet.
Yes.
While in the non-vascular one, many times you put the tourniquet.
Why
what is the second difference? What is the very important second difference which is there in a vascular case and a non-vascular case? The type of the flaps which are there. Usually in a case of vascular case, you will make a equal anterior and the posterior flap so that both have got the good supply. While in the non-vascular case, usually the posterior flap is bigger than the anterior flap, so that the scar line is not the end one, but it is on the front which is there, so that there is no pain. Sometimes these patients, they have got a lot of neuroma formation is there. So to avoid that, you make a bigger posterior flap as compared to an anterior flap. But in the case of the vascular one, because the vascular supply which is there, this should be almost equal. Okay, so these are two main differences between the amputation for a vascular and the non-vascular case.
I would just like to add on that, sir, that in amputation, how do you cut the nerve?
Pardon, sir?
How is the nerve cut in a vascular case?
So the
Are you there?
Yes, sir. Yes, sir. Can you repeat your question, sir?
How is the nerve cut in a vascular case or in a case of amputation?
The bone.
The nerve. The nerve ends. How's the nerve cut? Any special technique of cutting the nerves?
Yes, sir.
What is it?
So by it's sharply cut by pulling.
Yeah, you pull it and you cut sharply with a old knife. Why is that done? Why can't you use scissors to cut it or cautery?
To prevent neuroma formation.
Right. So, and phantom limb.
Phantom limb.
Right. Okay. How much is the bone cut from the site of incision?
So 15 centimeters in case of below knee amputation. From
15 centimeters. No, how much? How much? From your incision, how much should the bone be kept?
Sir,
At least 5 centimeters, okay?
5 centimeters.
Right. And what about the periosteum? What is to be done?
Blunting of the or bone wax should be applied, or the end should be their perio.
Yeah, the periosteum should not be stripped.
Yes, sir.
Right. Should not be stripped. Okay, that's fine. Should I ask you something more on amputation? Okay, I think that's you've done it. You done well. Do you know the names of various sites? Names of amputation at various sites?
At various sites are raised amputations for digits. Then
Okay, partial foot is what?
4-foot amputation. So
What is it called? What is Lisfranc's? What is Chopard's? What is Symes?
Symes are above the ankle Symes.
Ankle disarticulation is Symes.
Yes, sir.
Partial foot is Chopard's. Okay, what is Gritty-Stokes?
Not sure, sir.
Is knee disarticulation. Okay.
Okay.
Right. And what is hemipelvectomy? Hindquarter?
Pelvic disarticulation.
Pelvic disarticulation. Hemipelvectomy is you remove the acetabulum.
Okay, sir.
And hindquarter is the that portion of the pelvis. Of the pelvis.
Thank you, sir.
Right. So, Professor Ajay Khanna, sir.
I think that we have done enough now. Yeah.
Right.
Yes, sir. Yes, sir. Because both the cases were similar.
Right. That's what you asked.
I think the other examiners may ask if they, Dr. Vivek, Dr. Mumtaj.
Dr. Pooja, is there any role of arterial bypass?
No, sir.
Like,
Sir, in this case, there is no role because we don't have a target distal artery to do the bypass.
Okay. So, any, like Dr. Ajay Khanna has asked, the local vascularization techniques, are you aware of that? Does it help?
Yes, sir.
Yeah, how does it help? Like, does it help in reducing the pain? Because thromboangiitis obliterans, the most morbid problem is the severe burning pain. So it needs to be relieved, and only medication really doesn't serve the purpose. What kind of medications do you use for relieving pain? Is it opioid or it is NSAIDs?
Sir, we go according to the WHO pain ladder. So we'll, depending on the severity of pain,
yes,
we administer the NSAIDs or the weak opioids or the strong opioids.
No, Dr. Pooja, please. In the case of Burgers, do you use opioids or you don't use opioids?
So we don't use opioids.
Why? You just said you use opioids. That's why I stopped you. Why don't you use opioids?
Sir, further vasospasm causing the...
No, it's habit forming. He's a young fellow. It'll be habit forming. He'll become dependent on it. You've turned a Burgers fellow into a drug addict.
Okay, sir.
Right?
Yes, that was the aim of asking this question.
Right.
Thank you, Pooja.
Thank you, sir.
Any questions from other faculty, please? Pooja, do we have any questions to be clarified?
Sir, Pooja?
Yes, sir.
Do you have any questions to be clarified
Why?
with the faculty?
Yeah, I have one
Doubt.
question, sir, to ask Pooja.
Please, sir.
Pooja, nowadays we don't do sympathectomies. It has been taken off from the books also. What are the indications still where you can go for sympathectomy?
Sir,
Lumbar sympathectomy.
when the patient rest pain, continuous rest pain despite post amputation. So to relieve the rest pain, we do sympathectomy in a case of Berger's disease.
No, but still it is not done. You see, do you see it is done in our units and
No, sir.
in any of the unit? Why? It has interestingly, it has been taken from the Bailey textbook also. In new Bailey textbook, they don't mention lumbar sympathectomy. In the previous editions, they were one page or one paragraphs were there giving the details, indications, what are the confusing structures, but now it is taken off from the textbooks also. Why?
Sir, because it doesn't have much. It only increases the blood flow to the skin and not to the vessels. So the cause is not relieved. The blood flow, the blood supply to the lower limb is still compromised, and only the blood flow to the skin is improved.
Yeah, one reason is this. Second is that within 6 months to 2 years, most of the patients, they regain their vasomotor tone and the symptoms reappear, or the effect of the sympathectomy wanes in most of the patients, in spite of undergoing this invasive procedure. So there are indications if you want to prevent an impending ulcer or a non-healing ulcer.
Yes, sir.
Intractable ulcers.
Yeah.
Intractable.
So just to hasten the healing process or to prevent that. So that is the indication only, and otherwise it is not recommended now, this procedure.
Right, sir.
Pooja, do we have any questions? Faculty, any other faculty, any other questions or comments? Anna sir, we'll take a call to close, sir.
Yeah, I think so.
Faculty, thank you very much. Thank you, Dr. Pooja and Dr. Vaishnavi for joining this evening. I thank the invited faculty, Dr. Vivek sir, Dr. Mumtaz sir, Dr. Hemant sir for kindly contributing the case. I thank faculty who could not join here. They've sent a message, still their government meeting is not yet over. Kerala, because they have a lot of corona cases, still they are still challenged. So with the permission of the faculty, we call this session a close. I would request if any one of your department has a right iliac fossa mass case for the next week, because we are presenting an upper abdominal mass. So we thought we will have a mass abdomen. We'll try to compile so that more effective.
We've got one case. I'll ask my president to provide.
Please, sir. Thank you very much, sir. Thank you. By Tuesday or Wednesday, if they can share your name,
Right.
then the candidate's name,
I will do that. I'll do that.
Thank you very much, sir. Thank you very much. So, faculty, thank you for joining us. And our resident faculty, Kanna sir, Karnakaran sir, Hitesh sir, Hemant sir, Srinivas Pai sir, again, thank you for joining us in such a short notice. And all the faculty has been kind over a phone call. They agreed to concur to join us. I would recommend, please permit your PGs to present a case in this forum so that we keep improving on the quality of discussions what we go on. So with that few words, I thank all the faculty and we call this session a close. We look forward to have you on board on coming Friday also. Thank you very much. Good night. Good night,
Thank you.
friends.
Thank you very much, sir.
Good night, sir.
Good night, sir.